Hello everyone, my name is Steve DeMeester. I am a general and thoracic surgeon practicing in Portland, Oregon. I have been here for about 3 years now. Before that I was at the University of Southern California and Los Angeles for about 20 years. I have a focused interest in esophageal diseases, and an area of great interest, particularly over the last several years, has been paraesophageal hernias. We've certainly seen an explosion of these types of hernias, and as we're learning, they are challenging. I'd like to welcome everybody to this three-part series. First, I want to acknowledge that it's a very difficult time as we are all facing the challenges of the coronavirus and what that means as physicians and as surgeons, as our practices are disrupted, and as friends and families and patients are concerned about and perhaps even developing the viral infection. I certainly hope all of you are safe and healthy. But with this disruption comes an opportunity. While our surgical practices are interrupted, it is an opportunity for us to explore the science and discuss together some of the concepts and some of the challenges we face with these paraesophageal hernias. So, in collaboration with the IHC and supported by BD, Bard, Beckman Dickinson, we've put together a three-part series that will really dive into paraesophageal hernias. I hope that you find this series informative and useful, and we'll have a question and answer session at the end where we can hopefully get together and discuss some of the more controversial areas. So again, thank you to the IHC for this opportunity and for BD for sponsoring this event. As I said, we'll plan to discuss really in depth paraesophageal hernias. The title for the series is Paraesophageal Hernias: History, Fundamental Concepts, and Adjunct Techniques to Improve Outcomes, or hopefully improve outcomes. These are my disclosures. I do have research support from Bard, speaker and consultant. That's the main conflict with this talk. I also have research support, and I'm a speaker and consultant for other companies as well. We'll plan to do this as three parts because a single episode I think would be far too long. Each of these parts I hope to be around 30 or 35 minutes. Part 1 will cover the natural history of paraesophageal hernias, risk factors for the development of paraesophageal hernias, diagnosis of a paraesophageal hernia, and then the historical context of paraesophageal hernia repairs, where we've been, which will help perhaps us understand where we are. In part 2, we'll talk about the fundamental concepts, including the indications for repair and the timing for repair, areas that are changing somewhat with current data, critical steps and techniques during the repair of a paraesophageal hernia, the role of a fundoplication and perhaps things like gastropexy and so forth, and current outcomes with repair. And in part 3, we'll talk about adjunct techniques during repair for the huge hiatus. So we'll look at cholecystoplasty, diaphragm relaxing incisions, and then explore the whole controversial area of mesh use at the hiatus. So with that, let's get started. We'll start with, as we said, part 1, which will take us through some of the natural history, risk factors, and historical context for repair. Hiatal hernias are a common problem in the population. We get some information from a study done back in 2005 in a small county in Sweden. And what they did was bring in every third patient or so from this area for an upper endoscopy. So independent of symptoms, they had an upper endoscopy, and they found that a hiatal hernia was present in about 25% of the population. This study was repeated in a similar county in Sweden in 2018, and interestingly now the prevalence of hiatal hernia had increased to 68%. Again, independent of symptoms, just random selection of people in this area of Sweden for an upper endoscopy. So this suggests that hiatal hernia frequency or prevalence is increasing in the population. There are 4 subtypes, but 2 basic categories of hiatal hernias. The most common type of hiatal hernia is a sliding hiatal hernia, and we'll discuss the typing in a minute here. But sliding hiatal hernias are associated with reflux disease and are more common in men. The other major subtype is paraesophageal hernias. These increase with age as well and are more common in women, and we'll talk about some of the factors that lead to paraesophageal hernias as we go along here. And we're likely to see, as I alluded to, a lot more of these paraesophageal hernias, and that's because the U.S. population is aging. This is the census data from 2000, and you can see that there is a large segment of the population that's in the 70, 75, and even 80-year-old range, with over 6 million females over the age of 80, and of course, elderly females are at the highest risk category for a paraesophageal hernia. So we're likely to continue seeing an increase in these hernias. So how do we define the hernia subtypes? Let's make sure we're all on the same page together. A sliding hiatal hernia is defined by the GE junction being located above any hernia. So you can see in this diagram here, the normal GE junction is located below the hiatus at the angle of His. With a sliding hiatal hernia, now the stomach has protruded through an enlarged hiatus, but the key factor is this GE junction remains above the hernia. On the upper GI barium swallow study here, you nicely see perhaps a little bit of a Schatzki's ring. That defines the GE junction right there. Here is our hiatal hernia, and the defect in the diaphragm is right here. So this is a sliding hiatal hernia. And if you measure this compared to the spinous bodies here, you can get a sense of the size of that hernia. Endoscopically, we can also determine the type of hiatal hernia and can measure the size. So when we put the endoscope down, we can identify the GE junction. We can also identify the diaphragm, and we can take the measurements on the endoscope here and measure this distance. Looks like this is probably a 3 centimeter or so hiatal hernia. We can also define the type. In the retroflex position like this, with the scope curled around looking back on itself, we can see that the highest portion of the hernia, or the part of the hernia most elevated into the chest, is in fact the GE junction. So the GE junction is sort of the bottom of the pit here, which would mean the GE junction is on top of any of the herniated stomach, which would make this then a sliding type hiatal hernia. Paraesophageal hernias are subtype into 2, 3, and 4. The least common subtype are the type 2, which are in fact the true paraesophageal hernias, where the GE junction remains in the abdomen and a portion of the fundus has slipped up or herniated up into the chest next to the esophagus. So para means next to, so here you have fundus next to the esophagus, which means that the fundus is above the GE junction, defining a paraesophageal hernia. These type 2 or true paraesophageal hernias are quite uncommon. I've only seen several in my entire career. Much more common are the type 3 and to some extent the type 4 paraesophageal hernias. These are also called the mixed paraesophageal hernias because in both of these the GE junction and the fundus of the stomach are up in the chest. The difference between a type 3 and a type 4 is that type 4 has some other organ herniated into the chest in addition to the stomach. Most commonly this is colon, but it can also on occasion be small bowel, pancreas, portions of the spleen, and so forth. So the key feature again is the GE junction and the fundus of the stomach are up in the chest. for type 3 hernias. And again, fundus is on top of the GE junction next to the esophagus, so that's paraesophageal hernia. And these type 4s, or complete interthoracic stomachs, a very large type 3 or type 4 stomach here. This is type 4 because the colon's up as well. Here the GE junction tends to be lower down, and you have this complete upside down stomach. But again, most of the stomach here is above the GE junction, confirming that this is a paraesophageal type hernia. These large type 3 and type 4 hernias are associated with volvulus in most cases. Two classic types of volvulus. The most common is the organoaxial volvulus, or the complete upside down stomach. So the stomach has rotated 180 degrees on its axis and is upside down in the chest. These typically come down quite nicely. More difficult are the mesioaxial volvulus stomachs, where the stomach is actually folded in half. These tend to develop quite a few adhesions and are more difficult, in my experience, to reduce and straighten out than the organoaxial type. And these also are associated, in my experience, with more risk for acute complications. Radiographically, you can confirm the presence of a paraesophageal hernia. These type 3 and 4s, here again in this upper GI study, the GE junction is probably located somewhere in here, and you see fundus of the stomach herniated above the GE junction, the diaphragm in that location there. And in this one we have the organoaxial volvulus, the complete upside down interthoracic stomach. We don't really see the GE junction well. It's probably somewhere in this location here, but again, both the fundus of the stomach and the GE junction up in the chest with the complete interthoracic stomach here. Endoscopically, we can confirm the type of hernia as a paraesophageal hernia. Here again, the scope is in the retroflex position. We see the GE junction here. Here is the rim of the diaphragm, and in contrast to the sliding hernia, where the GE junction was at the base or the pit of the hernia, here in fact we see the pit of the hernia, or the deepest part of the hernia, is the fundus of the stomach, with the GE junction closer to the diaphragm here. So this would define a paraesophageal hernia, with the deepest portion of the hernia being the fundus of the stomach rather than the GE junction. Now, an area that has not been well studied is, where do these hernias come from, both sliding and paraesophageal hernias? The natural history is really poorly understood. When I moved up to Portland, we had access to a very large system database of upper GI studies. So we used a word scanning software program to search these reports for the word hernia. We then searched for people that had at least 2 upper GI studies, at least 5 years apart. We assumed that 5 years would be a reasonable interval to see a change or a development of a hiatal hernia. So we used this word scanning program to find the word hernia, and then we found patients that had at least 2 upper GIs, at least 5 years apart, and this is what we ended up with. There were 210 patients with a total of 526 upper GIs, and some of these patients had 3 or 4 upper GI studies, and we reviewed all of these for this study. In 121 patients, unfortunately, the upper GI images were not reliable to confirm the hernia that was defined on the report. So we reviewed all the films, and if the films were not adequate to confirm the report, we dismissed those. That left then 21 patients that clearly on review of the films had no hernia on the baseline upper GI and had a hernia on the subsequent upper GI, and 68 patients that had a hernia on both the baseline and the subsequent upper GI. Those 2 yellow box groups then form the basis of the study. There were 89 people in the study, 27 males and 62 females. And this is how it broke out. So on the initial upper GI study, 21 people had no hiatal hernia present. Over a median time of 99 months, the subsequent upper GI showed the development of sliding hiatal hernia in 16 people and the development of a paraesophageal hernia in 5. So this is really the first time that it has been shown that a paraesophageal hernia can develop de novo in someone that had no previous hernia on prior radiographic study. So this is initial development straight from no hernia to a paraesophageal hernia. We had 55 people that had a sliding hiatal hernia on the initial upper GI study. At a median of 84 months later, the sliding hernia was stable in size in 11 people, increased in size in 30, and actually changed from a sliding to a paraesophageal type hernia in 14. So 80% of these people with sliding hiatal hernias over time had a change either to an increased size of the sliding hiatal hernia or transition from sliding to paraesophageal hernia. We had 13 people that started with a paraesophageal hernia on the initial upper GI study. At a median of 97 months later, the paraesophageal hernia was stable in size in 5 but had increased in size in 8. So again, the majority of paraesophageal hernias changed over time as well, increasing in size. In 23 people, there were more than 2 upper GIs, either 3 or 4 studies. On the second upper GI, then, there were 13 people that had a sliding hiatal hernia over a median time interval from the second to the most recent, that could be the third or the fourth, upper GI. It was stable in size in 3, increased in size in 9, and again, in one patient, changed from sliding to paraesophageal hernia. Likewise, there were 10 people that had a paraesophageal hernia on the second upper GI and over a median time of 34 months to the most recent upper GI study, whether that was the third or the fourth. The paraesophageal hernia was stable in size in 5, but had increased further in size in 5 people. Now, in 2 of these patients where the hernia was stable, they already had a complete intrathoracic stomach, so any further increase in size really wouldn't be possible. So again, demonstrating that the majority of paraesophageal hernias continue to increase in size over time. So here are some representative upper GI studies from our series. Here in 2000, we can see this initial upper GI study, diaphragm right in here. So GE junction is below the diaphragm, all the stomach below the diaphragm. And then 10 years later, 2010, now you can see the outline of the paraesophageal hernia. So we have a patient here that went from no hernia directly to a paraesophageal hernia. And here is another person with a clear-cut sliding hiatal hernia, a little Schatzki's ring defining the GE junction right here, diaphragm in this region here. So here we have a sliding hiatal hernia. Now in 2010, clear evidence again of a paraesophageal hernia with GE junction in this region here, and the sliding hernia has transitioned to a paraesophageal hernia. And here in 2001 is an individual with a paraesophageal hernia. You can see a little bit of a volvulus in the stomach right in here. Here it is, the GE junction's probably down in here somewhere. So paraesophageal hernia here, and then has gone to a complete intrathoracic stomach, GE junction there. So transition from paraesophageal hernia to complete intrathoracic stomach over time. Well, what are the risk factors for development of a paraesophageal hernia? Well, that study that I just showed you, that is hopefully to be published pretty soon, demonstrates that one risk factor for development of a paraesophageal hernia is the existence of a sliding hiatal hernia, since over time, fair number, in fact about 27%, almost a third of sliding hiatal hernias over time transition to a paraesophageal hernia. Another risk factor is elderly patients. They tend to have weak tissues. Over the years, the chronic stress on the diaphragm related to the positive intra-abdominal environment, the negative intrathoracic environment, aging tissues, and so forth leads to these hernias. Kyphosis is a particular risk factor for paraesophageal hernias. Very nice paper senior authored by Jeff Peters, looked at this issue. There's been others. The University of Pittsburgh also published on the role of kyphosis and scoliosis in paraesophageal hernia pathogenesis. But what you can see here is the depiction of the Cobb angle, which is the angle of the spine. And if you mark that Cobb angle and measure it, that is in fact a risk factor for paraesophageal hernia development. It's believed to be related to change in the tension dynamics at the hiatus related to this curvature of the spine. In addition, there's evidence that in patients with hernias, and in particular paraesophageal hernias, there's likely collagen defects. There's been several studies. We'll look at a little bit of data, but it's quite likely these patients have collagen defects that participate in the development of these hernias. Clinically, most of you are probably aware, if you look at a patient with a paraesophageal hernia, it's not uncommon for them to describe having inguinal hernias, umbilical hernia, ventral hernia problems in the past. So these patients tend to be hernia prone, and that's likely related to a collagen defect in these people. This is one study. There's been, as I alluded to, several of them, but this is one study looking at the issue of collagen defects. They had 48 patients with type 1 hiatal hernia and reflux disease, and they compared this to 14 control patients with no hiatal hernia that were undergoing surgery for gallbladder disease or other things. At laparoscopy, 2 biopsies were taken from the frontoesophageal ligament and 2 from the diaphragm, the crura, left, right, and midway up the hiatus. And then they examined the tissues using transmission electron microscopy. And in the control, you can see a very nice organization of the fibers here. And if you look at the hiatal hernia group, there's dilatation of the spaces between the fibers, the swollen sarcotubular structures, focal degeneration, and extended disruption in these fibers. So clear evidence of defects in patients with a hiatal hernia. How do we diagnose a paraesophageal hernia? Now, paraesophageal hernias may have classic reflux symptoms, and interestingly, it's not uncommon that the patients will say, I used to have heartburn and sort of classic regurgitation symptoms, but it went away. And that's probably when they transition from a sliding hernia to a paraesophageal type hernia. So heartburn symptoms may be present, they may be absent. Oftentimes, patients with large paraesophageal hernias, the symptoms are more subtle. Chest discomfort after meals, particularly a large or heavy meal, they feel uncomfortable. They tend to stop eating those types of meals, and they may tell you, no, I do okay with meals, but ask them what they're eating. Well, I try to stay with soups and light foods. Well, why is that? Well, if I eat a big heavy dinner, I just get this pain and don't feel good. So you got to be inquisitive a little bit. But oftentimes they already have modified their diet because of these difficulties. They may describe dyspnea after a meal, a sense of fullness in the chest, a heaviness, a little short of breath after they eat a big meal. Sometimes they describe gurgling in the chest. And then dysphagia with solids is not uncommon as well, likely related to some of the distortion of the GE junction related to these large hernias. A common sign in people with a paraesophageal hernia is anemia, and we'll touch on that a bit more here. So anemia associated with paraesophageal hernias was actually described way back in 1967 by Lee Collis, the same surgeon that described the Collis gastroplasty. In his classic paper published in Thorax, he reported that anemia was present in 30% of his patients with a paraesophageal hernia, and he actually attributed the anemia to 3 forces: the negative intrathoracic pressure, crural diaphragm muscle movement, and the sliding effect of the stomach slipping across that hiatus. He coined the term riding ulcers related to the local trauma that happens as that stomach slides back and forth across the hiatus. And he reported that when you corrected the paraesophageal hernia, there was a dramatic improvement in anemia with a 5.4 gram rise in hemoglobin postoperatively. Interesting, despite that report, we all know that we don't call these ulcers riding ulcers. We call them Cameron ulcers. And that's related to this publication in 1986 by Alan Cameron, where he noted these linear gastric erosions near the diaphragm and the frequent association of anemia in people with large paraesophageal type hernias. Again, he suggested the erosions were due to local trauma as the stomach slid across the hiatus, and said they were the source of chronic blood loss and anemia in these patients. So despite Lee Collis actually describing very eloquently these ulcers at the level of the hiatus, the term that we now use commonly is a Cameron erosion. The association between anemia and paraesophageal hernias and the resolution of anemia with repair of the hernia has been also confirmed in more recent studies. This is from Don Lowe and colleagues up in Seattle, and they showed that 45% of their patients had anemia at the time of paraesophageal hernia repair, 32% had known Cameron lesions, and with repair of the esophageal hernia, the anemia resolved in most of the patients, 71%. Multivariable analysis suggested that the anemia was most likely to resolve in females under the age of 70, but there was no difference in resolution of anemia whether the patient had or did not have identified Cameron lesions. So what that means is that the majority of patients really don't need an exhaustive study for the source of their anemia when they're known to have a paraesophageal hernia. Instead, they should have paraesophageal hernia repair, and in those that have persistent anemia, then a more detailed and thorough investigation can be undertaken. But most of the time, anemia is related to the presence of a paraesophageal hernia and resolves with surgical repair of that hernia. So what studies should we use to identify a paraesophageal hernia? I think an upper GI is really the go-to study. It best delineates the size and type of the hernia. It will show you how much of the stomach is herniated into the chest, show you how much tortuosity of the esophagus is present, whether there's a volvulus, whether there's obstruction, and so forth. CAT scans are quite sensitive to show the hernia. They are the best study to show that it's a type 4 hernia and identify other organs in the chest, but they don't delineate the type of hernia quite as well. High-resolution manometry can be useful. Oftentimes the catheter won't go beyond the diaphragm. It tends to coil in the hernia sac, but really what you're looking for is information about esophageal body function, which you can get even if you can't get the catheter down below the diaphragm. Oftentimes there is GE junction outflow obstruction if you do get the catheter to go all the way down into the stomach, below the diaphragm and below the hiatus. But that GE junction outflow obstruction is likely related to the tortuosity of the esophagus and GE junction because of the hernia. So in general, I don't think we need to pay much attention to that GE junction outflow obstruction. If you have to urgently operate on a patient, of course you don't have time to do a high resolution manometry, and I think it's perfectly appropriate in those patients to just do a partial fundoplication. If you have a patient that has evidence of significant reflux disease, Barrett's esophagus, esophagitis, then I do try to get a motility study because my preference is to do a 360 or Nissen fundoplication in those patients given the severity of their reflux disease. Upper endoscopy I think is important. You can, as I said, define the hernia, identify sliding versus paraesophageal, measure the size of the hernia, but most importantly look for mucosal abnormalities, whether it be strictures, Barrett's esophagus, adenocarcinoma, or some other important abnormality that you should know about prior to planning operative repair. Here's an upper GI study, and it nicely delineates some tortuosity to the esophagus. And in these cases, it's kind of nice to see that because this suggests that we should have some length to the esophagus when we straighten this out. Hopefully, we will not need a lengthening procedure because we have some built-in redundancy of the esophagus. Here we see the classic upside down stomach, the organoaxial volvulus. And these are relatively straightforward in general to repair. The problem is they oftentimes are associated with a very big hiatal defect, and that really is the challenge in the repair, not so much reducing the hernia. And here we see evidence of a volvulus in this stomach here with a sizable paraesophageal hernia. Here's a high-resolution manometry study demonstrating the outflow obstruction that we oftentimes see. So here is the upper esophageal sphincter, which is very hypertensive in this patient. Here we see a contraction, peristaltic wave coming down, and you see evidence here of the bolus obstruction related to outflow resistance at the GE junction, likely related to the tortuosity of the paraesophageal hernia. But we can see that this patient has appropriate motility in the esophageal body for Nissen fundoplication. Well, let's talk now about the surgical history for paraesophageal hernia repairs. Most of these in the past were done as transthoracic operations. When I started my career over 20 years ago now, essentially all of these were done as a transthoracic operation. Occasionally we did these as a laparotomy, but this was before the days of laparoscopic surgery, and we believed at that time the transthoracic approach was really ideal. This paper by Griff Pearson and colleagues from the University of Toronto really sets the standard for these repairs. Now what you'll notice is this paper, published in 1998, goes through pretty much the lifetime experience of Griff Pearson, a very prominent, well-known thoracic surgeon at the University of Toronto. And what you notice is that this represents a 36-year experience from 1960 to 1996, and there's only 94 patients. That's about 3 patients a year for a very busy thoracic surgeon. What that tells us is that there's been a dramatic increase in the prevalence of these paraesophageal hernias, because I think many busy foregut surgeons are doing over 94 repairs a year. So this is dramatically changing disease. Now, getting back to Griff Pearson's paper, the nice thing about this paper is it's a very uniform approach to this hernia. 97% of the patients had a left thoracotomy and a Belsey Mark IV repair. A Belsey Mark IV is basically an anterior toupee. Toupee is a posterior partial fundoplication. The Belsey Mark IV is an anterior partial fundoplication. It's different than a door or the anterior fundoplication reported by Watson and colleagues. This is done through the chest, but in essence it's a partial fundoplication. He added a collis gastroplasty for a short esophagus in 80% of patients. Now bear in mind, this goes way back in time, before the era of proton pump inhibitors, and many of these patients had pretty severe disease with strictures and esophagitis. So it's a little different era in some sense, but nonetheless, bear in mind that he had a collis gastroplasty in most of these patients. Incredibly low operative mortality rate for going back into the days before epidural catheters and so forth. Morbidity was 19%. Median follow-up for the 90 available patients long-term, now this is 72 months after the operation, median follow-up. Barium upper GI done at 1, 5, and 10 years in these patients demonstrated incredibly only 2 anatomic hernia recurrences, 2%, and both of these were in patients that did not have a collis gastroplasty. They both had a reoperation and got a collis gastroplasty at the reoperation. But this objective hernia recurrence rate of 2% is pretty much the lowest reported anatomic objective recurrence rate in the literature. And this was accomplished by a very good thoracic surgeon with a consistent approach, left thoracotomy, collis gastroplasty in these patients. Well, times have changed and we don't repair paraesophageal hernias transthoracically anymore. We first reported a comparison of our outcomes between the open era with primarily transthoracic approach and the laparoscopic approach back in 2000. Majid Hashimi was our fellow, and he looked up our early experience and noted a significantly higher recurrence rate with our laparoscopic approach compared to the conventional open, mostly transthoracic approach. At first, this was heavily criticized, but subsequent results have confirmed, in fact, a very high recurrence rate with the laparoscopic approach for paraesophageal hernia repair. Shown here are the results from the Oschlager multi-center randomized trial, where they reported with primary laparoscopic paraesophageal hernia repair a 5-year recurrence rate of almost 60%. Likewise, Bernard Delamain, who did the world's first laparoscopic Nissen, looked at his own personal series of paraesophageal hernia repairs, and at 8 years noted a 66% recurrence rate. Now, putting that into perspective, these are first-time laparoscopic paraesophageal hernia repairs, and we're looking at over 50% recurrence at 5 years. If you look at another very complex, sometimes hernia in the human body, ventral hernias, they are known to have a high recurrence rate, and this is reoperative data. So after a third ventral hernia repair, we can see that the hernia recurrence rate at 5 years after a third reoperation is still less than what we have with a first-time laparoscopic paraesophageal hernia repair. So that puts things a little bit in perspective. Well, I'm not suggesting that we should go back to paraesophageal hernia repairs done through the chest. No, there's no doubt that laparoscopic paraesophageal hernia repair is here to stay. The national inpatient sample of almost 80,000 patients looking at benign esophageal diseases, again, not all of these were paraesophageal hernias, but what they showed was that for patients with paraesophageal hernia repairs from 2000 to 2013, the rate of laparoscopic approach went from 4.9% to 91.4%. So a complete transformation over that 13-year time frame from open transthoracic or open laparotomy to laparoscopic repair. During that same time period, the complication rates for paraesophageal hernia repairs decreased from 26% down to 10%. Other studies have shown that laparoscopic repair of paraesophageal hernias is associated with reduced morbidity and mortality, fewer transfusions, shorter hospital stay, and lower costs. So no doubt we are not going back to an open transthoracic approach. But it might be reasonable to think a little bit about what made the transthoracic approach so good. How was Griff Pearson able to report such excellent results? And how did we see that difference between our laparoscopic approach and our open approaches in our series back in 2000? So if we sit back and think about it a little bit, I think there are a couple factors that lead to the difference in outcomes between the transthoracic and the laparoscopic approach. First, with a transthoracic approach, you can really get full esophageal mobilization. You can divide the critical vagal branches to the pulmonary hilum that tether the esophagus, and we'll come back to that in a minute. If you read Griff Pearson's paper, you also realize he had the ability to assess esophageal length and tension. First of all, the diaphragm's in a neutral position. With a thoracotomy, chest is opened, diaphragm's in a neutral position. It's not being artificially pushed upwards by a capnoperitoneum. So the diaphragm's in neutral position, so you're not being misled on esophageal length. And what he would do is pick the esophagus up after reducing the gastroesophageal junction down below the hiatus. He'd pick the esophagus up, and if it was bowstring tight, he knew there was tension on the repair. If the esophagus was loose and he could move it around easily, he knew tension wasn't present. Well, we can't do that with laparoscopic surgery. We're not in the chest, first of all, and our ability to really assess tension, as we'll talk about down the road, is quite limited. He frequently used cholecystroplasty. We talked about a different patient population to some extent back then. Nonetheless, he used it and it was quite effective. We can do cholecystroplasties laparoscopically, and we'll talk about that down the road. If you've ever done a transthoracic approach, you know that with this Belsey spoon, the device we slip behind the right crus to push the vena cava away, you can really get very deep crural stitches on the right crus as well as the left crus. And perhaps that's an advantage of the transthoracic approach. I think we can get pretty good bites laparoscopically, probably not quite as good as what we get transthoraically. And then lastly, don't forget what pain might do to limiting activities in patients. With a thoracotomy, which is pretty much the most painful incision you can place on the human body, these patients aren't back playing golf or doing the activities that they might be doing much sooner after a laparoscopic surgery, where they feel quite normal long before the crural repair has really sealed in. So I worry sometimes that patients get back to activities too quickly and disrupt the crural repair, leading to a recurrent hernia because their bodies just aren't limited by the same pain that they had in the open era. Well, let's talk a little bit about the transthoracic versus laparoscopic mobilization of the esophagus. Certainly an effort, and we'll talk about this, is to mobilize the esophagus up in the mediastinum. The challenge laparoscopically is that what really tethers the esophagus is these vagal branches to the pulmonary hilum. And so here's a diagram from Netter and another one from Moore's illustrated anatomy. And what you can see here is the vagal trunk is coming down here, and there are a myriad, this is the recurrent laryngeal nerve here ducking around the aortic arch, but there are a myriad of branches from both the left and the right vagal trunks that are supplying the innervation of the heart and the lung. So these plexes of vagal branches to the heart and lung are tethering the esophagus. And if you just mobilize, so in this region here will be our inferior pulmonary vein. So if you just mobilize the esophagus up to the level of the inferior pulmonary vein, you really aren't accomplishing that much because all of these tethering branches are left undisturbed. To truly mobilize the esophagus is going to require getting up above the inferior pulmonary vein, which you see here, all the way up along the trachea and along the pulmonary artery to divide these branches to the pulmonary hilum, and that is treacherous territory. Now when you're in the chest, through the left chest, we put a Penrose drain around the esophagus, pull it up and away, and then we can mobilize this all the way up to the aortic arch, circumferentially, and divide all those branches to the pulmonary hilum. That, I would suggest, is quite treacherous and difficult to do laparoscopically or even robotically, because this is really no man's land and you can get in big trouble up there very quickly. So the question is, can we replicate or achieve what we can accomplish with the left transthoracic approach laparoscopically? As we talked about, I think the limitations of working through the hiatus up in the mediastinum make it difficult to replicate the transthoracic mobilization all the way up to the aortic arch. We certainly can try, but that is a difficult task. The other option is to cut both vagal trunks, as described by Pellegrini and colleagues. Cut one vagal trunk and you gain 1 centimeter length. Cut both, you gain 2 centimeters length. And the reason that works, of course, is because by cutting the trunk, you don't have to worry about dividing all those pulmonary branches. But that's probably not the best approach to go dividing the vagus nerves. If you divide one accidentally or deliberately to gain some length, probably not a big deal. Dividing both can certainly set the stage for gastric emptying issues. Well, what about adjusting the diaphragm position so that we don't have an artificial overestimation of esophageal length with the laparoscopic approach? That certainly is feasible laparoscopically by simply making a capno thorax. We can cut into the left pleural space or the right pleural space or both, which is my preference, and we'll come to that down the road. But by opening the pleural space, we put the diaphragm in a neutral position. It then gives us a true assessment of intra-abdominal esophageal length, and in addition, and again we'll talk about this down the road, it does reduce the crural closure tension. What about crural closure? I don't think we can get quite the same deep, thick bites of crural tissue that we can get with the left transthoracic approach, but we can get quite good bites laparoscopically if we are doing it well. The problem is that when we put these stitches in transthoracically or even open abdominally, we get a sense of the crural closure as we tie the stitch down. Unfortunately, our perception of crural closure tension laparoscopically or robotically is quite diminished. We'll go over some data on that pretty soon here. So we are a bit limited in addressing or assessing tension with the crural closure, but we can do things to improve that tension, and we will cycle back to that in another talk. A shortened esophagus, as we said, we can cut the vagus nerves and gain 1 centimeter for one and 2 centimeters for both vagus nerves. We can attempt additional mediastinal mobilization, but again, unless you're really dividing all those vagal branches all the way up to the pulmonary artery, you're not gaining much ground. And then lastly, we can add a callus gastroplasty, and we'll talk more about that later. Certainly, I would encourage everybody to stress the importance of limited activity after laparoscopic paraesophageal hernia repair. Patients need to know that these diaphragm repairs are tenuous and they take several months to really heal up. My own personal practice is that I restrict patients to no more than 10 pounds of lifting for 3 months postoperatively. So I discourage them from doing any type of real core exercises, crunchies, sit-ups, that kind of thing, and no lifting more than 10 pounds for 3 months. I'm super aggressive about that because I know most patients will cheat a little bit, and I really want them to take it easy so that the diaphragm repair has the best possible chance to heal up before they really stress it. Well, what about paraesophageal hernia repairs? What do we know about the outcome with paraesophageal hernia repairs? First of all, we know that they are incredibly effective. As we talked about, anemia gets better in the vast majority of patients, and symptomatically patients get better as well. This study looked at 162 paraesophageal hernia repairs. Most of these were type 3 paraesophageal hernias with both the fundus of the stomach and the GE junction in the chest. Majority of patients had Nissen fundoplication, the others having a partial fundoplication. Mean follow-up about 2 years and complete symptom relief in 66% of patients with improved or resolution of both typical and atypical symptoms. And you can see the change in the symptoms from preoperative to postoperative here with the significant p-values for the whole gamut of symptoms. We also have studies confirming improvement in pulmonary function testing as well as dyspnea symptoms with paraesophageal hernia repair. This one from Don Lowe and colleagues in Seattle looked at 299 patients who had pre and post-op pulmonary function testing. The testing was done 3 to 4 months after Hill repair for the paraesophageal hernia, and they defined significant improvement as an FEV1 increase greater than 12%. They reported that most patients, 67%, had improved dyspnea symptoms after the surgery, and 80% of patients had improvement in their pulmonary function tests. Significant improvement was present in 41%, and again, that's the group with greater than 12% increase in FEV1. The overall median improvement in FEV1 was 9%, Improvement overall in forced vital capacity 9%, vital capacity 8%, and diffusion capacity 3%. Significant improvement, they noted, was most common in the patients with the largest hernias. That does not come as any surprise. If you had a near or complete intrathoracic stomach, you are most likely to have significant improvement in your pulmonary function testing. So paraesophageal hernia repair improves symptoms, corrects anemia in most patients, improves pulmonary function tests, but unfortunately recurrences happen. What are the implications of a recurrent hernia after repair? Well, oftentimes we hear people say that they're small and really of no significance, they're asymptomatic, but does the data really support that? It is true that most are small and most do not require reoperation, although that depends a little bit on the timing of the recurrence. But in terms of them being asymptomatic, there's less good data supporting that concept. This paper, published a decade or so ago, looked at symptoms in patients with and without a recurrent hernia, demonstrating that those with a recurrent hernia had significantly more heartburn symptoms than those without a recurrent hernia. This study from Brent Oschlager, actually two studies, one from 2006, another from 2012, showing between no hernia and hernia significant differences in pain, early satiety, and SF36 social or physical functioning, and then comparing no to a small or a larger hiatal hernia, showing that as the hernia size increased, symptoms tended to be worse. So there is some evidence that patients with a recurrence tend to have more symptoms and more impaired quality of life compared to those without symptoms, and that impairment increases as the size of the recurrence increases. Another study looking at symptoms and quality of life compared patients without recurrence to those with recurrence, showing again more heartburn, as you would then expect, higher PPI use, more dysphagia, and lower overall satisfaction if you had a recurrent hernia. And on top of that, reoperation for recurrence is not a great thing. So this study from England showed, again, as we mentioned, overall reoperation rate about 4 or 5%. But if you look at the subgroup of patients with a recurrent hernia, 15% of these patients did require reoperation. This was at a median of 24 months after the initial repair. Reoperation as symptoms more likely in patients with larger hiatal hernias, and the re-recurrence after reoperation was not trivial. So not only do we have a high recurrence rate with the first-time repairs, it does not seem to be any better with a reoperation. Here they reported 39% re-recurrence after reoperation with relatively short-term follow-up. And this is from Scott Roth and his group at University of Kentucky, looking at revisional paraesophageal hernia repair, again showing a very high recurrence rate with revisional paraesophageal hernia repair, 21% with less than 1 year of follow-up, and compared to the initial primary paraesophageal hernia repair, reoperations are associated with longer operative time, more blood loss, and higher hospital readmission rates. So pretty clear that a reoperation is necessary in some patients. Results are no better than the first time around, perhaps even worse, and they're more difficult. So the moral of the story has to be to try to limit recurrence rates. So in summary then, hernia recurrence after a laparoscopic paraesophageal hernia is unfortunately too common, data suggesting 50% or more by 5 years. Most of these are small and reoperation rates overall are low, although in the group of patients with a recurrent hernia, 15% or so will need a reoperation, and if you dig into the studies, reoperation rates are higher the earlier the hernia recurs and the larger the recurrence. Now, some or many early recurrences tend to be quite large as well, so they're a bit linked, but nonetheless early and large recurrences are at increased risk for needing a reoperation. Recurrences can increase in size over time, so even though they start out small, they can increase in size and become more symptomatic, as Oschlager suggested in his studies. Patients with a recurrent hernia have more symptoms and worse quality of life. That's been demonstrated in multiple series compared to those without a recurrence, and larger recurrences have worse symptoms. The risk of acute complications requiring urgent or emergent surgery after a paraesophageal hernia repair, so a recurrent paraesophageal hernia, the risks for this are not well established, but it's likely related to the timing of the recurrence. As we said, early recurrences, probably within the first 6 months or a year, tend to be larger, and they may be associated with more risk for acute complications, obstruction, incarceration, and so forth, than smaller recurrences that happen further out over time. Nonetheless, given all of these concerns, our goal, as we said, should be to minimize hernia recurrence after paraesophageal hernia repair. So we have finished part 1 of this 3-part series. Our second part will cover fundamental concepts about paraesophageal hernia repair, including the indications and the timing for repair, critical steps and techniques during the repair, the role of fundoplication, gastropexy, G-tubes, and so forth, and then outcomes with repair. And then in our last segment, we'll talk about adjunct techniques that may be useful to help improve some of these outcomes. So thank you for your attention, and we will look forward to the next 2 steps and then a nice question and answer session following that. Thank you and have a good day.